All right. Hello, everyone. Hello and welcome to another of our live streams. It's a pleasure to be with everyone out there. Glad to have you all tuning in. For those of you that don't know me, my name is John Lustria. I'm the Director of Education at the National Museum of Civil War Medicine, and I'm thrilled today to be joined by two of the co-hosts of the Poor Historians podcast, Max Naines and
Hello.
Aaron Anderson. Thanks for being with us, guys.
How's it going? Yeah.
Hello. Thanks for having us on.
In addition to being incredible podcasters about medical history, which we were featured on one of the episodes not terribly long ago. Our very own Kyle Dalton appeared on there talking about the innovation of the ambulance corps. They cover all sorts of other medical innovations and mishaps and whatnot in their podcast. But in addition to being medical history podcasters, they're also emergency physicians in real life outside of the podcasting world. So they're here to offer a modern perspective on Civil War era wounds, injuries, treatments, toolkits, and all sorts of things of that nature. So it's going to be, I think, a really interesting program today. I'm looking forward to it. As always, of course, go ahead and let us know in the comments where you're watching from. I see we got Jan from Orlando, Florida, Christina from Butler, Pennsylvania. It's always great to see where people are watching from. If you enjoy the video, make sure you hit the like button and share and send it to all your friends, people you think might enjoy it. This one especially would be good to send to any doctor or nurse friends that you have in your life, because I think they'll find this one especially interesting. And the best way, easy, free way to support the museum is just make sure you're following us across our social medias. We're on Facebook, YouTube, Instagram, TikTok, and be sure and check out Poor Historians across all those platforms as well. So we're all over the place, and that's the best way to stay up to date with what we have coming, and it's an easy, free way to support us. If you want to take your support to the next level, consider becoming a member of the museum. As low as $25 a year goes to support programming like this. And we are a private nonprofit, and you get something out of it as well. You get free admission to all of our museum locations, as well as the Seminary Ridge Museum up in Gettysburg, Pennsylvania. We have a reciprocal membership program with them. So one membership gets you admission to 4 different museums. You can't beat that. And you support programming like this. So yeah, with all that said, let's go ahead and jump into it here. Thanks again, guys, for being with us. And I wondered if maybe you could introduce yourselves a little bit to our viewers. Tell us a little bit about yourself and what drew you both to become a medical professional and then to medical history to start the podcast. Say a few words about how that journey was. We'll start with you, Max.
Sure. So yeah, emergency physician for last 10 years now, and believe it or not, Aaron and I were the first two that decided to try to start the podcast when one cold winter morning we're both humanities majors from back in college, so both English degrees, like creative writing kind of people, and we were saying, geez, work together, but we want to do a creative project. And so Aaron was talking about maybe doing some sort of writers group. And I said, I'm a podcast addict. I'd love to start a podcast. And after workshopping a bunch of ideas, we both figured out we really liked medical history. It was pretty easy for us to transition as, modern physicians to talking about some of the things and putting a little bit of a twist on it from our nowadays perspective. And one thing led to another. We got Mike involved, and we're over a year later, still going strong, I think.
Yeah, I agree with all those things, right? The podcast came out of a good idea over whiskey, and a lot of good things start that way. So
more than one.
I'm a practicing emergency physician as well for over a decade now, and the medical director at my local community emergency room. And both Max and I trained at a large trauma center, urban trauma center. So I think our perspective will be kind of interesting in that regard as far as what we see and such. But the other thing to notice about medical history is how many things we still do today that came out of, the history long ago in the Gilded Age. And so, I mean, triage is something that looks like we might be talking about today, and we still talk about that daily in our current work. So yeah, it's just good to know your roots so you can understand where a lot of these things come from.
Absolutely. And speaking
Oh,
of
John,
that,
there you are.
this will be great to have you all offer that kind of more modern perspective, because I might play a doctor on TV, but I'm definitely not a doctor. I'm a historian by training, and so a lot of the stuff that you just said there about how the Civil War kind of lays the foundation for a lot of practices that we benefit from today. It's great to hear you say that as well, and it's good for me to hear you say that because I know I'm not just making stuff up, which is always a positive. And so you alluded to this a little bit, Aaron. I wonder if maybe you could talk a bit about the types of injuries that you all personally have treated, the most in emergency medicine, and what similarities or differences that you all see with the type of work that you do in emergency medicine today with what you imagine Civil War surgeons might have conducted in, a mass casualty situation like a Civil War battle.
Sure. Yeah. Well, so we do see the wounds that were seen in the Civil War when you're working at a large urban trauma center. So, for example, where now my work it's in a quieter locale, so I don't see quite as many of those types of injuries. Word. Yeah. Well, I'm not working right now, so I can say quiet all I want. We're a superstitious lot, you'll find out. But the big difference would be scale, right? So we're civilian physicians, and we're not working at wartime. So I think that, the modern battlefield medicine analog to what happened in the Civil War is, it might be a lot of similar injuries, but we would never see it at that scale. So we'll deal with penetrating wounds frequently in the emergency room. But yeah, I think the most I've ever seen at once might have been 7 or 8 at once, which is still, that's, pretty impressive amount of people that are hurt and need help, but probably nothing on the scale of what they saw at these giant battlefield hospitals.
Yeah, and I mean, to that point too, the type of injuries you can expect to see will depend on where you practice. So, for instance, we're both in residency. You're working at this level 1, which is the highest designation of trauma center, meaning that not only and most of these are located within big cities. So not only will you see a lot of the trauma, whether it's gunshot wounds, whether it's motor vehicle crashes or motorcycle accidents that are around the hospital, but when you're training at a level 1 center, all of those things that happen outside of your hospital that are in the region will come to you as well. And so you're going to expect to see a lot more volume of trauma and that sort of thing in that type of setting. But that being said, when you're working in a smaller community hospital, you might be surprised what walks in the door or gets dropped off at the door. And, so it's hard to predict completely, but your volume will definitely depend on what sort of hospital you're working at.
Yeah, I think some of the consequences too of people that were, maybe had poor nutrition, or they didn't have a lot of the things that we could give now to try to treat infection and so on. Those things we definitely still deal with: bone infections, overwhelming infections that affect the whole body from whatever source, which we call sepsis probably these days, is something that we deal with on a very regular basis. So there are a lot of similarities. I think that the differences, oh man, I mean, the resources are vastly different. In addition, the baseline health of the population is vastly different. So there's so many things that have gone into our modern world that help us deal with things very differently from the way they could even have the possibility of dealing with them in the Civil War era.
Yep.
Yeah, that's an interesting point, and one I want to underscore about the difference of scale of the sort of trauma injuries. I mean, that says it all right there, that the largest, in your career that you've ever seen, the largest number of people at one time is, 7 or 8. But on Civil War battlefields, I mean, granted, more than, a few doctors are involved, obviously, but still, the Battle of Antietam, the bloodiest single day in American history, you're dealing with 17,000 plus wounded. I mean, it's literally impossible for, the number of surgeons that were available to deal with it. So I mean, that's an extreme example, obviously, but even, one of the smaller Civil War battles, you're dealing with even several hundred casualties is a lot. So that whole idea of scale, I don't think can be underscored enough. So that's worth noting. And then I thought that was interesting, Aaron, that you're talking about that, like, some of the type of diseases and like the malnutrition and things of that, like they're perhaps a bit more common than you might expect. And thankfully, we know about germ theory and such today. I mean, there's lots of important differences in the resources, like you were just saying. But that's interesting that rather than there being more similarities in the types of trauma wounds that you see, there's perhaps more similarities when it comes to kind of diseases.
Yeah, well, and there's also the interesting flip side of that is, although some things stay the same, gunshots are gunshots, knife wounds are knife wounds, high impact trauma from, granted, they didn't have a lot of 70-mile-per-hour stagecoaches back then, that could cause problems. But so that stuff is a little bit different. But, in the modern age, we also don't see a ton of some of the diseases they had then. It's not that we don't ever see things like tuberculosis. We do see it once in a while, but we don't see it on the scale. Yeah, I've had 3 or 4 cases that I've seen. And so, that being said, then it was endemic. It was, all over the place. And so it's kind of interesting that even though we have certain things that are very similar, there are some things that are, fortunately, we don't have to deal with like they did. And even in that time when germ theory was really just still in its early stages, they didn't have antibiotics. So even if they had pinned that down, we have some advantages nowadays.
Right. Even sanitation as well. I mean, cholera seemed to be common then, right? So you have cholera outbreaks all the time, if I have my history correct. And, Haiti is having a horrific cholera outbreak right now because they've collapsed and the government's non-existent. But I don't know if I've ever seen a case of cholera here in the United States. So those things are in some ways a thing of the past if you have modern sanitation and so on. And that's a big thing that also wasn't present back then too. So people would get to the hospitals, I'm sure, in a much sicker state sometimes than they are now.
Sure. And not that folks need a reminder for this, but make sure you wash your hands and keep things clean. But
just think for a minute on what the fecal oral transmission route really means, and you'll wash your hands pretty well.
Yeah, exactly. I forgot to mention this at the beginning of the program, but be sure, everyone tuning in, to let us know in the comments if you have any questions. We'll be sure and get to as many as we can. And Jan here asks a question that sort of leads into my next question, actually. The Civil War sees the birth of triage as we know it today. And I'd be curious for you to talk a little bit about how you might triage in some of those larger casualty situations. And I'll frame it as Jan did here. She says, knowing that you have tools, medications, and antibiotics, do you still have to make those, quote, immediate decisions regarding which wound has to be addressed first if presented with multiple wounds or multiple trauma patients? So I wonder if maybe you could talk a bit about triage.
Yeah, well, and not only triage, but kind of how to do it in a less than ideal circumstance. So yeah, to get to that point there, triage, I mean, just the overview real quick is it's just sort of trying to figure out when a patient comes, say, into a modern ER, triage is trying to figure out who's the sickest person, who needs the most immediate attention. But when you turn that into a wartime situation, or what can be deemed a mass casualty event, and meaning that is what defining a mass casualty event really means, it's an event such that it outstrips your current resources. So if you are working by yourself as an ER doc out in the middle of nowhere, and there's, one nurse in town and it's you, and 3 people show up after a car accident, that could reasonably be a mass casualty event because it will strain those resources. But when you get into something where you're expecting hundreds and hundreds of wounded and basically all at once, we do have a system that we use now. We call it the SALT system. It's an acronym. It's Sort, Assess, Life-Threatening Injuries, and Treat, I think. And basically, it's just a way for us to take this otherwise difficult to control situation and try to pare it down to the most simple things. And so your first step in that is to try to figure out who really doesn't need your attention immediately. So you call out, who can any of you hear me, and can you walk over there? And anybody who can do that probably doesn't need your attention in the next few minutes, right? So you've already kind of sorted some of those out. But when it comes to some of the more severe injuries like gunshot wounds, part of it is a true judgment as to whether you can do anything for the person in the present setting. Now, in a modern tertiary or regular hospital, we have a lot more resources that we can do, especially in today's era. But when you're in a battlefield, whether it's modern times or whether it's Civil War, and somebody has a gunshot wound to the head and they're not breathing or moving, there's nothing you can do. And so you have to basically move on from there. But the trickier part is those folks who have wounds to like arms or legs or chest or belly, where you might be able to do something and intervene. And in the modern time, I'm sure we'll talk about this a little bit as we get to the cases you mentioned. That's kind of a trickier spot. And you do have to decide, hey, if somebody is shot in the chest and they're having trouble breathing, can I stabilize them? And if I do I even have the resources to help after that? If they go to the hospital or the field hospital, as it were, in the Civil War, do we have the resources to actually help that person longer term? And you have to make those decisions kind of on the fly. And none of us like to be in that position, but there are times when, that's kind of what happens. And Aaron, what do you think? Did I leave something out?
No, I don't think so. I think sadly in the modern world, I mean, I can think of multiple examples where I'm sure this has been applied. I mean, you think about the Las Vegas shootings and the larger school shooting, even any of the school shootings that we have regularly. You have the Waukesha Parade disaster and so on. I mean, all of those cases, this principle had to be applied. And the next steps Max was talking about, have people walk to the side, and then you have people, if they can't move, raise your hand if you can hear me. Those people are still responding. And then you go and assess the ones that aren't responding. And unfortunately, the saddest category in that triage system is black, which is expectant, meaning there is no way with maximal resources I would be able to save this person. And actually, in that situation, you have to leave those folks, even if they're still maybe slightly responsive, because there are absolutely still wounds, even in the modern setting, that we just can't fix. And Max alluded to that. But there are definitely at the time interventions you can do to stabilize quite a few of these injuries similarly. And we might get into that here. I would say there's also a good time to call out our EMS colleagues. I mean, we have a lot of frontline heroes in our country every day who run our ambulances and such, that go out and take care of these folks in the field and then bring them to the hospital. And without those people, emergency physicians can't do our jobs. So, and they do a lot of these sort of initial stabilization maneuvers. And we may get into this too, but so we sort of are that access point to advanced care and trying to get folks to operating rooms and getting the right specialists involved. We also need both of those, both sides, but the people that go out and actually pull the people out of the injury zone or the field are the ones that also do some of these initial stabilization maneuvers.
Yeah, one of the points that you made that I want to highlight that I thought was especially worth noting is it depends where you're wounded, both where on your body and where, like, physically in the world you're wounded.
Yeah,
if you think on the battlefield, you mentioned, Aaron, I think when if someone is brought to the hospital, like a long-term care facility type hospital, you have a wealth of resources available. But if you're, say, a first responder out on the field, whether you're showing up at the scene of one of these disasters or on a Civil War battlefield, your resources aren't necessarily going to be more limited because you only have the medicines and bandages that you can, sort of physically carry with you out there. And so in that situation, if you're away from more of that, triage is going to be, we got to focus on stopping the bleeding for the people as quickly as possible before perhaps even you might assess some of the other situations. Okay, about who do we make sure we try and get to a long-term care facility first, and things like that, which is a key part of the first part of the Letterman plan, as we've talked about on these videos before, at the field dressing station, stopping the bleeding and then deciding who gets taken via ambulance to the field hospital where surgical procedures and things happen. But I think that's a really key point, not only where physically on your body you're wounded, but where in relation to, a medical facility you're wounded, how far away from you and how far away from the resources are you. So I think that's certainly very notable.
Yeah, one way to sort of illustrate that is, an ankle sprain. If you go even further afield and you talk about wilderness first responder training, I mean, if you're way out in the middle of nowhere and you sprain your ankle, that could turn into literally a life-threatening injury if you're 2-3 days out in the middle of nowhere. So it's all a degree of the context for the injury.
Mm-hmm. And that's why having a kind of well-denoted triage system is so important, because in many cases, especially in the civilian world, you're rarely prepared, when someone is injured, and so to have a system to fall back on is so important, to know kind of what to do, both as the injured person and the medical professionals as well, to have that equipped, and especially in mass casualty situations, either in wartime or in our sort of modern world. It's especially important to have that kind of system, because in any sort of mass casualty situation, sometimes you hope never to have to make these decisions, but sometimes you have to make some uncomfortable calls. And I thought that was an instructive definition, Max, as a mass casualty situation is anything beyond your ability to to care for, which I mean makes total
Absolutely.
sense.
That's true. Yep.
I've never thought of it that way.
The goal at the end of the day is to try to do the most good with the resources you have for the most amount of people. And the reason you have to move beyond some of those folks, and when Aaron alluded to basically what we call a black tag, and that's like our system for these mass casualty events are color coded, coordinated. So the people who are otherwise walking well, or green, they're green, so they got time to get to them. Yellow is our folks that may have a life-threatening injury. You have a little bit of time, there may need to be some interventions, but you have a little time to make that call. That might be the person who may not be able to walk over there, but they can at least talk to you and they're awake and conscious. And then you have red, which is the immediate life threat unless you do something. And those are some of the tough folks that you have to decide, can I do something? And if I do something, is that going to take every bit of the resource that we have from somebody else who may benefit more, and that's the tough part. And then if somebody is obviously either already deceased or has a completely non-survivable wound in your estimation, that's a black tag. That's a tag that just says, unfortunately, we can't do anything here. And so we have to focus elsewhere.
Yes, and one of our viewers here, Christina, just in the comments cited that exact triage system that we have today. At the time of the Civil War, they're not using colors, but they're operating under similar principles. Although today, and you can correct me if I'm wrong, we prioritize head and chest injuries because we want the brain, the heart, and the lungs to keep doing things.
We use, so with trauma, and I think this is a fairly international standard. I'm not sure, but we use, it's called ATLS. It's Advanced Trauma Life Support. It's a way of thinking, which we try to keep things simple in these situations. So, A, B, C, D, E. So airway, breathing, circulation, disability, which kind of refers to neurologic situation, and exposure. And it's sort of thought to be the hierarchy of things that in that order, if you don't address them, are more likely to be immediately fatal or devastating. So it's, what that assessment can happen literally within seconds. If a patient is, has a gunshot wound and they're rolled in on a gurney by paramedics, it's like, hey, how's it going? Tell me your name. And if they can wake up, they say, yo, my name is Bob. And you're like, great. That told me they have an airway, they are breathing, they're circulating well enough to at least perfuse or get blood flow to their brain. And they're making sense. If they're speaking in sentences neurologically, we got something to work with there. And then we've got to move to like exposure and kind of find wounds. And you do this very rapidly. And so, if, for instance, their airway's okay, they're breathing, they're talking to you, And as you get down to the C part, circulation, you notice there's a big wound to like the thigh and where the femoral artery is, and that's spraying blood. We have to stop there. We have to fix that. We have to stem that. And then we can move on to checking their neurologic status or, doing a full exposure. And so if you get there and you're talking to them and they're not talking to you, you have an airway problem until you know otherwise. You stop there and then you have to fix kind of in that order. So there is a bit of an order. We don't quite localize it to region. We sort of, body systems, airway and breathing are number 1 and 2. Then you get to circulation. You fix what you can fix, and then you move to the next one. And you kind of run through this list whenever you have to. If something changes, they were talking a few minutes ago and they're not anymore. Let's go back to airway, breathing, circulation, and try to figure out where the problem is.
Yeah, from a trauma standpoint, I would say severe head wounds are probably there at D. That's usually where you assess their neurologic status. So they don't necessarily come first. And I think the thinking there is that, well, if you don't have a heart to pump the blood to the brain, you're going to get in trouble a lot faster than the other way around. And that's not to downplay head injuries. It's just that, well, let's, we'll stabilize and then you deal with that when you get to it. Of course, that's in a modern, so we're kind of moving into talking about how we address this once they're in the hospital, usually, right? ETLS is, I think, fair to say, Max, don't you, more of a hospital-based way of attacking?
Although our paramedics they're certainly trained in those principles, right? That's what they do. They may not do the exact course, but they're doing the same thing. They're starting with the airway, the breathing, and all that sort of thing.
And not all paramedics can manage an airway in the modern sense. So they might just, in the United States, this gets into the other thing. A lot of times there's this sort of scoop and run, what it's called, the scoop and run philosophy for paramedics, which is you just, okay, you have a very injured person. I'm going to maybe put a tourniquet on, maybe do something to control bleeding. But at that time, I'm still moving as rapidly as I can to get to the hospital. And in a lot of cities, you'd be amazed at how fast they get us folks. I mean, I've seen ambulance reports where it's, transport times of 5-6 minutes for on the other side of the city. And I just like, wow, good on you. Just get that person here and we'll take care of them. So, but yeah, absolutely. I think that's a very familiar model.
Yeah, that's helpful, and definitely something I'm probably going to use on tours when talking about sort of how we do it today. The whole idea that the ABCDE type thing, the whole idea that it's systems as opposed to sort of body locale.
Yep. And then, sorry, we'll just do one more thing. We can get excited talking about this stuff. So the exposure part, that's quote unquote the last step there. But that's where, especially with penetrating trauma, you really sort of get the full picture of what you're dealing with. So exposure, this is where when somebody arrives in the emergency department, you see a lot of folks in an ER. If you go there, they're walking around with sort of these special scissors. Those are called trauma shears. And what those are used for is if you have a sick patient, you're just going to, pretty much just cut off all their clothes within the first 15, 20 seconds of when they arrive. And you're looking for wounds. And you're looking for where they might have been hit. And that includes all sorts of places you wouldn't think. You have to look in the armpits. You have to look in the groin. You especially always have to look at their back. So it's a pretty common pitfall where you might miss a large wound on the back. And, you got to make sure you sort of deal with where all of those are and gets you a sense of what you're going to do, especially with penetrating trauma. So where I was, we would have a simple thing. We just have paper clips. And so you take a paper clip and you unfold it to make a V. And then you have a piece of tape and you would tape the paper clip facing up on the front, facing down on the back of the patient. And then you take an x-ray and you're looking at where does that paper clip line up with
a bullet wound
are. Yeah, with a bullet hole. So you're looking for bullet holes and say, oh, okay, well, we're going to localize that and figure out what we're dealing with. So it's a picture that will stick in my mind. We have these big old lights in the trauma bay and you just have all these paper clips attached to tape, just sort of waiting for the next patient. So yeah, a lot of those little things, you're always systematic. You're always A, B, C, D, E in that order, and you stop at each one. And that's how you make sure you don't miss things.
Fascinating. Yeah, I'm definitely going to use that. With the Civil War, invasive surgery isn't quite where it needs to be to consistently help people with head and chest injuries. I mean, they're aware enough to know that it doesn't have a super high success rate, even if they don't know why. So they tend to leave those folks aside, and so they focus on limb injuries. So they're much more region of the body focused in terms of Civil War triage. And so that's interesting to hear, and it makes total sense, why you all do it the way we do it now. So
Yeah.
that's
Oh, definitely.
good.
And there was a time too, around that time, where there were prominent surgeons writing that we'll never be able to do chest or abdominal surgery. There's nobody survives it. There were surgeons writing in medical journals at the time that we don't think this will ever be possible. And then along comes, germ theory and anesthesia, and they rethink that now. It's incredible what they can do now. But there was a time when, they did focus on those regions because they were afraid that any possible intervention inside the chest or the abdominal cavity would just ultimately be fatal. They weren't wrong.
Yeah.
They just
Right. I mean,
weren't
it's
really
reasonable,
sure of
right?
the
Just
reasons, right?
Lot bigger black tag population there with your triage. But that's,
Right.
I mean, if you're looking at how to allocate resources, that makes sense. I mean, it is a cold calculation, but it's also what you got to do. So I understand why they would have made the choices they made.
Absolutely. Just a quick question from Beth in the comments. Did they have such things as quick clot during the Civil War,
Oh, great
or
question.
herbs other
Yeah.
than just a tourniquet? And no, we're pretty much just talking tourniquet and some bandages. Nothing like quick clot or anything of that nature.
Yeah. I mean, the number one thing too, whether you've got fancy stuff like quick clot, pressure is the number one thing that is going to stop most bleeding. The source is really internal. You can't touch it with your finger and put a pressure on it that way. No, you're not going to be able to do much. But the any bleeding from big arteries, whether the arm, leg, or whatnot, pretty firm pressure, you'd be surprised how much it can stem things. There's times when it's not going to be enough, but at least for the moment, it might help.
Yeah. Well, it's always been my first maneuver at the bedside. And of course, I have the luxury of having multiple people around. So you try to find, where is this actually bleeding? And the first thing is just very, very direct, hard pressure. And it's not comfortable for the patient, but yeah, it's the key is to try to, even if you're going to use a gauze, maybe a tiny little square, and you just put pressure on that and try to hold it. Yeah, quick clot is great. I think there are a lot of battlefield uses for quick clot, and I'm going to plead ignorance on that. I mean, I did not serve and didn't do battlefield medicine at any point. So, but yeah, that I think is used quite a bit. Tourniquets, though, it's interesting that came up. I mean, we use those routinely still. So tourniquets have made a huge comeback as far as controlling extremity bleeding.
They're back in. They're trending now.
Yeah. I mean, and we do, I mean, ideally when it's put, you'd like to know the time it's put on, because as soon as you have a functional tourniquet that's actually doing the job of stopping bleeding, that needs to come off within a certain period of time. Otherwise you're going to lose the whole limb. But they're absolutely something that's used in the field to try to stabilize that bleeding for sure.
And it's not for not trying. I know that they did use a lot of compounds and things like that back then, and even some natural things. So I like stuffing nicotine into wounds and things like that. Technically, it could clamp down blood vessels and stem some bleeding. I don't think it's going to stem huge bleeding. And then you shoved a bunch of plant material into a wound, so you've got a new problem with infection. But they definitely tried a lot of those things. I don't think they didn't have the stuff we have, but even quick clot and all the fancy stuff, pressure is one of the best ways to stop any bleeding.
I mean, they had cocaine in the Civil War, right? I mean, cocaine is still used as a what's called a vasoconstrictor. So it makes the blood vessels smaller. And we still could absolutely use that to this day usually for nosebleeds is the thing we still use it for, ironically.
Which
it's a little bit old school.
I'll point aside without getting too far off field here. A lot of people will say, well, you think of the image of folks with bloody noses doing cocaine. The reason that cocaine can seemingly cause that is it erodes, it narrows the blood vessels so much that they can sometimes erode the middle part of their nose, the septum, and it can kind of break down over time. So it's actually so good at clamping down blood vessels, it can wear down the skin and tissue, and that can then expose the blood vessels to more harm and damage. So interestingly, it can be used to slow down and stem bleeding, but it can cause it in different ways.
Yeah. And I think that applies though more to, I don't know if it would work on the types of bleeding that you would have to control immediately. That needs to be pressure or tourniquet.
Yeah, I would say so.
Some sort of surgical approach.
Sure. One other question here, and this is something that I've wondered myself. Christina asked if most times the bullet is still left in the body today. During the Civil War, prior to the if they were going to perform an amputation, they would always remove the bullet. And I've heard a few different things on this, so I'm curious for your take on that.
Yeah, so we go ahead, Aaron. I think we talked about this a little bit on a recent show, but I'll give my perspective after you.
Yeah, this is actually probably one of the biggest changes I would say in medicine. We treat the effects of the bullet, not the bullet itself. So if surgery is needed, it's needed to repair the damage the bullet has done, but you're not going to change anything by taking a bullet out. I mean, they're inert. They tend not to cause, in rare cases, a long time, they can kind of erode and cause a little bit of irritation, I suppose. But no, we don't go after the bullet itself. We need to know. So as I said before, like you're marking those gunshot wounds to see where the bullet is, but that's so you can try to figure out what it did, not so that you can go get it. And sometimes that's a bit of a hunt, but yeah, we absolutely, I don't think at all go after the bullet itself anymore.
No, not for its own sake. I mean, there may be times when it is lodged adjacent to something very dangerous or important, and there are some calculated decisions that surgeons may make in getting those. But generally speaking, once the bullet comes in, as it's traveling hypersonic speed and it hits the skin, friction burns its way in, through all that tissue. A lot of times they're kind of considered to be fairly, and they're not completely free of bacteria, but they tend to burn a lot of bacteria on the way in. And so if the bullet lodges and the person is otherwise okay, and the bullet path did not do damage to something like a lung or heart, we're going to leave it alone. The exception being that a lot of folks, especially in the modern age, for instance, when I was a medical student, when we worked, one of the rotations I did was trauma surgery in an even bigger trauma center in a major city. And patients would come back to clinic. So we'd see a lot of gunshot wounds, unfortunately, a lot of violence. And then, folks would show up in clinic perhaps months or years later with, they had been shot in the arm, and then they had this painful lump, and the bullet had been there all along. They knew it. But if it was in the soft tissue, sometimes your body will slowly start pushing it towards the surface, and it can become painful and irritating. And so every once in a while, we would take them out just, to alleviate, as long as it's right at the soft tissue. You anesthetize the skin, you make an incision, you pull out the bullet. And I got to do one or two of those. And I will always remember I pulled the bullet out from like the arm, and it had been there for years, so it's like covered in a little bit of calcium. I pulled it out, and I was going to put it in a plastic container that I had, and the surgeon stopped me. He said, "Absolutely not. Hold on." He ran over and he got a metal basin. He put it down. He's like, "You got to hear the clink."
Yep.
He was right. You had to hear the clink.
I mean,
so it's not, we're not diving in right after somebody is shot.
No.
That's a case where years and later it's caused some discomfort, and it's safe to go get it.
Yeah. Well, if we're on Facebook Live, people are probably, old enough like me to remember Greg LeMond, who won a Tour de France with a bunch of birdshot still in his body. So, I mean, I think it's more, it's much more dependent on what damage is done.
Mm-hmm.
Fascinating. Yeah. Well, and it's interesting what you were just saying there, Max, about how sometimes it just works itself out over time. There are recorded instances of that from the Civil War. Where in particular, we just last week did a live stream about weird wounds and surgeries from the Civil War, to kind of get into the Halloween spirit of sorts. And there was one person she had a sewing kit in his pocket, and he was shot through the sewing kit, and for years later, just these needle fragments would pop out from time to time, which is sort of disturbing.
Oh my gosh.
Kind of wild. Anyway, before and I want to make sure we get to at least one case study with you all. I have one other sort of burning question that I've always wondered about and was curious for the opinion of an actual doctor. So one of the methods doctors during the Civil War would do to avoid amputation entirely, in the hopes that perhaps the patient might be able to keep some of their some of the limb, is something called a resection, where if the bone had been damaged, they would go in there and try and, to the best of their ability, precisely remove just the damaged bits of bone and leave the remaining limb, in the hopes that perhaps, like with an arm, you might be able to at least grasp something with your hand, or, you'd have a leg to stand on, kind of thing. Generally speaking, they weren't incredibly successful, but they succeeded in a number of instances. I would just be curious. I'm guessing we probably don't do that today. It's either an amputation or nothing, but maybe I'm wrong. I'd just be curious for your thoughts on that type of procedure.
Yeah. I mean, a lot of those are going to be very case dependent. And, certainly I'm not an orthopedic surgeon or a trauma surgeon, so let's throw that out there. But I mean, based on some of the things I've seen, I think there's a degree of how much bone is damaged. And so what people may not realize, I mean, we think of bones, and especially this time of year, bones and skeletons as sort of these inert things. But when your skeleton is constantly rebuilding itself. Every day you have cells that are making new bone and taking away old bone. And so inside the body with blood flow, a skeleton is a very living thing. And that means when a bone breaks, that the broken fragments start sending out chemical messages to each other. And so when that happens, all these cells called osteoblasts move into the area and they start laying down this new bone and or sort of bone-like substance. And then over time that becomes filled with calcium and then it hardens. And so if you break two bones, but they're reasonably close together, over time that'll knit pretty tightly, right? But if those two bones are further away, they'll do the best they can to try to catch each other and make what's called a callus. And it won't be in that case as strong as a regular native bone, but you can have bone fragments a fair bit apart and they may try to connect with one another. They won't look normal, but whether that can support your weight in a leg or support your holding something in an arm is very case by case. And when a surgeon nowadays decides, hey, I don't know if I can salvage this limb, there's going to be a lot of factors that go into it. Either the bone fragments are too splintered or they're gone, or there's significant vascular and neurologic damage that can't be repaired. That's all going to kind of go into the spot where they will maybe have to take the whole arm, but there's definitely times when they can salvage, and they always like to salvage. And I think we have a lot more leeway nowadays because we have so much more research.
They'll definitely try. I mean, so these are, this case you're talking about here, this would be a traumatic open fracture. So from an emergency room standpoint, that person's going to come in, I'm going to stabilize them, control bleeding, get an x-ray. If the bone's affected by the bullet, I know I have to call an orthopedic specialist. And if you're at a big center, you're going to have an ortho trauma specialist that really just deals with these injuries. And then if there's any effect on the blood flow, you're also going to have a vascular surgeon. And I think absolutely they're going to try to salvage the limb. I think the thing they always get are immediate antibiotics. They get a bunch of sterile decontamination of the wound itself. So I mean, these are cases where they go in and in the operating room, they're going to use, a huge amount of fluid and even fluid with antibiotics in it and wash that all out really well. And then they get intravenous antibiotics as well. And that helps a lot. I mean, I had a amazing week on ortho trauma as a student and watched these, subspecialists look at these, what I think you mentioned in some of these cases, comminuted fractures, meaning there's a bunch of fragments, and then they'll look at where the bones are, and then they would figure out ways to try to get a titanium rod from one piece to the other. And I think, again, I'm not an orthopedic surgeon, but that's a huge advance. You have these bits of metal that are fashioned to stay in the body, in perpetuity afterwards. So I haven't seen a lot of places where they sort of rely on the bone to knit itself. So that's probably the way those
very different now.
Because you don't have the strength. If it's shattered in pieces, like there's other cracks, you're not going to get that strength. So they would try to get from healthy bone to healthy bone with a plate or a rod or something like that. And again, I'm outside of my specialty here, so if anyone wants to correct me in the comments, they can. But yeah, I mean, people try to salvage. When I hear them talk, I think they do feel like the public has this understanding that, oh, you blew your hand off, we'll just come on in, we'll sew it back on. I mean, these cases are still very, very difficult, and there's absolutely a limit to what they can do. So there are a lot of cases where you're like, this is why people shouldn't play with fireworks. I mean, if it's that's the closest we get to a battlefield for most of our civilians. And if stuff blows up in your hands, especially, there may not be a lot that can be done. But yeah, I think that concept exists, but it's much more advanced, and a ton of the things with the antibiotics and the decontamination and such is why they're more successful today.
Sure, and that's a great point. There's just the surgeons today have just more tools and toolkit, like you were saying with the rods, titanium rods and things. We can, the overwhelming majority of Civil War amputations are coming as a result of a shattered bone, which we can deal with today. I mean, again, case by case situation, but we're just, maybe the better way to say it is we're better equipped today to deal with that. They just, there's only so much bones can do to put themselves back together. Again, I'm not I'm not a doctor, but if it's like a fracture, or a clean break, something like that, you put a cast on it and don't, punch a wall repeatedly, and it sort of, the body heals itself. It's amazing.
Have a lot more chance to heal well then.
It depends a lot on the type of it, the caliber, the bullet, the type of bullet, how far away it was. A lot of these wounds in the Civil War are pretty rough. I mean, there's spinning balls and high velocity, and then you got cannonballs and trap. I mean, those are always going to be difficult wounds. So I don't know.
Absolutely. Quickly in the comments before we move to our case study, Christina asked, how did they deal with broken bones, like a more traditional broken bone? They did actually have splints at the time of the Civil War. We have some on display in the museum. So they can set broken bones, but like we were just saying, the injuries that they're largely seeing are shattered bones because of the type of ammunition that's being used, like we were just saying there. Okay, let's tackle a case study here. We have 3 prepared. We're definitely not going to get to all 3. I want to get to at least one. And if people have enjoyed this, maybe we can get the gang back together and do it. Tackle another 1 or 2.
Yeah, definitely.
Let's take a look at the abdomen wound. This is an injury that happened to Sergeant H.T. Angel, age 23 years old. He's wounded in the sieges of Petersburg on October 28, 1864. Gunshot wound entered the abdomen about 3 inches to the left of the belly button. And so 4 days after being wounded, he's admitted to what would be probably a long-term care facility in Alexandria. So just a quick note, the Letterman plan, I'm presuming that he's already been to a field hospital, and certainly he's been stabilized via first aid after 4 days. Now he's in kind of long-term recovery after 4 days, which is pretty remarkable by Civil War standards, to be on the battlefront, to be wounded, and then 4 days later, you're in a long-term recovery facility. Let's see. So a small mass supposed to consist of omentum. I wonder if maybe you could explain omentum for people.
Sure. Yeah. So if you picture kind of in your head the like almost draw up any kind of picture of the intestines, usually what you're going to see is that they're kind of suspended. So they are oh, Aaron's getting his, is that a Netter's?
The textbook.
Are you getting a Netter's?
It's a Netter, yeah.
Okay, well, Aaron I'm sure that actually is helpful here. So your intestines are suspended by kind of a fatty tissue layer of sorts. That's what we refer to as the omentum. And it's if you get a wound to the abdomen, either intestine or omentum, the fat surrounding the intestine can sometimes pop through the wound. And so that's probably what they were seeing, just the sort of fatty surrounding of the intestines as it came through the wound. And if nothing else, it tells you that bullet went all the way into the abdominal cavity. All right, there you go.
Okay.
Yeah. All that fatty curtain schmear on the anatomically speaking on the intestines.
Fatty curtain schmear.
That's a technical term.
It's a NAINS technical term. Yeah. So that stuff, popping out, that's it tells you penetrating wound to the abdomen. So I mean, that's 100%. It went into the abdominal cavity, and there's going to be a problem.
Yep.
Yes. And problems are ahead. Spoiler alert here. The patient.
Do we want to, looks like, so should we talk a little bit, Max, about how we'd sort of deal with this in the acute setting?
Yeah, we can definitely talk. So here's exactly how this would play out in the so if this was not a Civil War, but somebody gets brought in with the wound to the abdomen in a modern trauma center, this would literally be, they come in the door, Aaron would say, hey, tell me your name. They can tell me their name. They can move their fingers or breathing. We would get to exposure and then see that the wound was there. They're going to an operating room. We're done. They're getting antibiotics. They're going to an operating room, and they will go in and explore, because any bullet or projectile that goes into the abdominal cavity, I was going to say penetrating is really the right word here. So a knife too, if it went into the abdominal cavity, something may very well need to be fixed. And they're not going in to take the bullet out. They're going in to see what's been damaged and what can be fixed. Because if that bullet went through the wall of the peritoneum. It's the lining of the abdomen. It could have hit anything. It could have hit, especially, it sounds like it was kind of left lower quadrant or left side of the abdomen based on what you were saying. So it, that's like large intestine is going to be right there full of fecal material, which you definitely don't want not in the large intestine and inside your abdomen. Depending on which track, which direction the bullet was going, your aorta is just off to the left side of the middle of the abdomen. You're going to have bladders kind of generally around that area, kidney, the ureter, the tube from the kidney. So all kinds of stuff could be wrong. That patient comes in, hey, how you doing? You can talk. Awesome. If you can't, we're going to put an air breathing tube in and get you right off to the operating room to see what's wrong. That would be the modern perspective. I miss anything, Aaron?
No, that's exactly true. And it's a exceedingly quick process. I mean, you're ready and there's people all around the patient getting IV started and putting monitors on, and you know where that patient's going. So I've even had the surgeon do the job of getting some blood tests and such, because that's one of the steps. And they're just like, I know where this patient's going, just get him to my operating room so I can take care of him. And I think they're worried. They've seen so many cases like this in the past where, okay, they might look okay right now, but they can just decompensate rapidly. This patient didn't. So I think the reason they go to the operating room so quickly is for hemorrhage control initially. So they want to make sure there's not something bleeding in there. They have to tie off or salvage, and that's, take their spleen out. It's a very common problem, all sorts of things like that. But then the second one, as Max said, is, maybe where this case, I can see some dark things in the future, because anything that goes into the abdomen, if it does, as Max said, injure any of the intestines, then poo's supposed to stay where it belongs. You can't have it just wandering around.
Exactly.
No free range poo.
Wise words. And so, we don't know what happened, in terms of, bleeding and hemorrhaging in those first 4 days after the wound was initially received.
Well, he had to stabilize though, right? Because he made it to the hospital. So
correct,
there isn't.
So there's that. The patient supposedly complained of no pain and seemed quite comfortable, except for some slight oppression. I'm not sure exactly what they mean by slight oppression. But yeah, the terms we've got to go off of. Let's see.
He had existential problems. I appreciate that.
He's given a milk diet, and stimulants and tonics were employed. And stimulants almost definitely refers to whiskey. They thought of liquor as a stimulant, even though we know it as a depressant. But they thought that kind of warm feeling you get when you have liquor as like having an energizing quality.
I've read about it.
No,
I've read about it. Yeah, I've never tried it, but
there is a huge crossover between alcohol and trauma. I mean, let's get that straight. I mean, so we often have people that'll come in and they have received stimulants before their arrival in our emergency department. Yes, of various types.
Doesn't make our job easier.
Yeah,
no, not at all.
So they're giving a milk diet, and they're lifting his oppression, and
so 5 days later, on November 7th, after he's checked into this hospital, brace yourself, folks. This part's a little gross. A hemorrhage took place from the rectum, amounting to 2 pints of blood. And again, on November 9th, 2 days later.
Well, so that's
not a good sign.
Yeah, it's not good. Not good. So one of the immediate problems with when you see a lot of blood from that area is you have no idea where it's coming from. So you can't look externally and figure it out. You have to look internally to say, well, what's bleeding? And I have my suspicions reading this just a little bit that you gave me ahead of time, that the problem is that bullet went in, did a bunch of damage, and it could have damaged some blood vessels that bled initially and then didn't. And I think I'll let you get towards the conclusion, and we can kind of talk about what did happen. But
right, well, and critically, they can't get in to explore, like you were saying, like you would do now, to see what happened. They don't know what happened in there, and so they're working blind.
Well, there's a wound to the intestines now, right? Because normally the inside of the abdomen, which is called the peritoneal space, is distinct from the inside of the intestines, right? So those don't ever connect. And the only way, even if you had internal bleeding
don't normally connect.
Right. If you had bleeding inside the abdominal cavity, the only way it's going to get to the outside world, which is what happened in his case through the rectum, there has to be a hole there for it to pass through. So we're in trouble now. This is not, and actually, when folks have, when they go home, and we haven't found any injuries at all from any type of trauma, be it car accident or what. Well, I don't think anyone ever goes straight home with return to care instructions with penetrating trauma to the abdomen anymore at all. But with car accidents and such, we'll say, look, come back if you have rectal bleeding, because that's a sign of internal injury of some sort or another. So definitely a concerning symptom or sign, or both.
Yes,
concerning.
They gave the patient opium and acetate of lead
There you
to
go.
check the bleeding.
That'll fix it.
Yeah, which it seemed to, and he only passed small quantities of blood once or twice afterward with his feces. Let's see, on
Improvement.
November 12th, so 3 days after the latest rectal bleeding, his appetite returned, and there seemed to be an improvement in all his systems. He continued to improve until November 21st, so like 11 days, or sorry, 9 days after that, when he had a chill. From this time, he had 1 or 2 chills daily, so presumably some sort of fever. Let's see, on November 23rd, he complained of loss of appetite and weakness, but he was not troubled with pain until the afternoon of the 25th, when his breathing became quite short and more difficult, and there was pain, increased pressure in the abdomen. This condition continued until death, which occurred on the morning of November 26th. So maybe talk us through what we think might have happened there.
Yeah. So I'm guessing the bullet goes in.
He seemed to sort of get better almost, and then very much not.
Yep. So the probably, not knowing the exact end of this, I think that, so the bullet probably goes in, it probably strikes the large intestine. It would be my bigger guess, because of the rectal bleeding, that's going to be the quickest path. It goes through that, but it goes through, and it takes a few days for the damage to really show itself. Or what might have happened, it caused some bleeding initially, and then that blood was seen a few days later. That's also possible. Or there's a very incredible phenomenon that when you injure something like an artery or a vein, it often will try to spasm itself off it kind of controls the bleeding. And so what you might have saw is he did have an arterial or venous vein injury to the intestine, and it spasmed off for a few days. But I suspect what happened is, as that bullet tore through, it then mixed the fecal material with all the surrounding intestine and then got that out into the abdominal cavity. And over days, what probably happened is he developed an abscess or a pus pocket full of bacteria and dead white blood cells trying to fight off the bacteria. And that can kind of eat away at tissues, and it might have eaten away at the lining of the large intestine. He starts getting the bacteria in the bloodstream. There's your chills. And then as that infection keeps spreading, it also might have done more tissue damage, caused more bleeding internally. And some of that may have been like, we're fine. And then we go off a cliff because the infection is going to take many days probably to develop, or it gets walled off in that abscess, that pus pocket. And then a few days later that ruptures. And then now it's just all over the place. And so when bullets or knives rip through tissues, the other problem can be, especially over this was like 11 days, 12 days. I don't know if it would happen that quickly, but you can develop what's called a fistula. It's a communication between two structures. You rip these two soft tissue, not soft tissue, but these two fleshy structures, they can kind of start to grow together and make a tunnel between them. And sometimes that can happen between a blood vessel and the large intestine, or a bladder and a large intestine. Really pick any two places, and you'd be surprised how these communications can form and cause big problems.
Yeah, and so they did perform an autopsy and they recorded it. And that's one thing worth noting about this. So this case is taken from the Medical and Surgical History of the War of the Rebellion, a sweeping 6-volume study conducted by the federal government during the war.
Nice light reading too.
Yeah, I mean, it'll put you right to sleep if you try and read it cover to cover, but the information in there is incredible. And there's just dozens of case studies. This is case 168. One of the other cases I selected is case 1653. So I mean, there's just oodles of them.
We're going to be here for a while today.
Yeah.
Yeah. Well,
let's go through all of them.
Yeah. This will be our last one for today. But anyway, those that do die, they perform autopsies, and which was in some ways kind of novel. The whole idea is, to gain medical knowledge to try and figure out what happened. Autopsies weren't necessarily looked upon favorably. The idea was that the body should be buried with people, with their family, and it should be as intact as possible, to be raised up at the end times. So even the fact that they're performing autopsies is notable. So they perform an autopsy on Sergeant Angel here, which is actually quite a provocative name since he doesn't survive. But in any case, let's see, where do we go? The missile had penetrated the abdominal cavity, passed through the mesentery, and between the intestines without perforating any of them, and had fractured and lodged in the body of the fourth lumbar vertebra on the left of the aorta.
Oh, wow. Okay.
Okay.
A portion of the ilium, about 2 feet from the iliocalical valve.
Ileocecal valve, yeah.
Ileocecal, yeah.
I'm doing my best with some of these medical.
You're doing great. You're doing great.
The ileocecal valve had become adherent to the peritoneum around the wound in the vertebra, and the intestine at that spot had ulcerated through, so that the discharges from the wound were poured into the intestine and thus carried off. The bleeding entered the intestines through this ulceration
around the wound in the vertebrae. So those are all parts of the small intestine, which is kind of jumbled up in the middle of your belly. So yeah, it's a really interesting wound. And so there's it's creating a passage out of the peritoneum again into the place behind it, which is not great, right? But it is a place where you can have bleeding that then stabilizes. So when you when you rupture into the posterior part of behind your belly, that's called the retroperitoneum. So peritoneum is the inside space, retro just meaning behind. You will you'll get bleeding into there that then, because it doesn't have anywhere to go, it'll actually pressurize and stop. And so the interesting thing in this case is, why did he bleed and get sick and then stabilize again for so long? And it's probably part of it, because it seemed to sort of stabilize for a time.
And the other thing I would point out there, so when they mentioned that it passed through the intestines without causing damage, but something hit the ileocecal valve, and this might be like a little bit of semantics, because the ileocecal valve is where the small intestine pops into the large intestine, and right around there is where your appendix is. So I'm guessing that, considering there was ulceration, something damaged it, and they're probably saying it didn't hit the intestines, thinking more the intestines proper. But that's the connection between the large and small intestine. So if something passed by there and caused that ulceration, that is probably it was a small wound that they didn't know about, and it did affect the intestines. They just weren't calling it intestines. They were just saying that this particular spot that was really a connection between two intestines, it had to have eroded through and caused a lot of what we saw. But it lodged near the vertebrae. So the bullet itself, other than causing the damage, that bullet was just sitting there, sitting next to the bones, and I'm sure it wasn't comfortable, but it sitting there was not the problem. The problem was the tract it took. And here's the other thing. When you'll see on like a lot of true crime shows or stuff like that, as Aaron was talking about, you got paper clips. If you put a paper clip here, because you saw a bullet wound right up here on the chest, and you put one on the back, it doesn't always mean it took a straight path. A lot of times it might, but I've seen I've seen cases where there's a gunshot wound to here, and you might find a bullet up here, because when they hit bones, they hit other structures, they can deviate their path in very unpredictable ways. So even if the bullet wound came to the left abdomen, it could have, just because it hit the soft tissue, it could have spun down to the right lower abdomen, which is where the ileocecal valve is. And it could have caused all kinds of wonky, zany, zany is a weird word for bullet path, but it really can be unpredictable.
That crazy zany bullet. There's even talk of a bullet embolism. So in rare cases, you'll get a wound, and the bullet will come in and it'll do damage and slow down, and it hits a blood vessel, but doesn't go all the way through it, and actually will get into the wound and then get carried off to some other part of the body. And you'd think this is, it sticks in my mind because I've only seen it once. So it's pretty rare, but yeah, once they're inside the body, you really don't know what they're going to do. They're going to do all sorts of crazy stuff and splinter, and who knows.
And that's the other thing too. This bullet might have hit the skin and splintered inside.
Yeah.
And one of those splintered splashed off down to the right lower abdomen. cut through the ileocecal valve.
Yeah.
And that's probably,
well, but you
probably
mentioned the fistula, though. It sounds like there's a lot of fistulization here between a bunch of different structures. And then I like how it says the discharges from the wound were poured in and carried off. So it's just, just leaking into the intestine.
And this was a time when there was the concept of laudable pus, hey, that wound is full of pus. It is delightful, because they didn't it's really bad. But it's, it was so commonplace to see infections and wounds, and this is a wound with an extremely high rate of infection, that I'm sure they're collecting all this stuff like, hey, they're healing. It's really just a spreading infection. Once it's in the bloodstream, this day and age, probably not going to turn out well.
Is there a last line to that case study? Am I seeing here looking at the notes, or?
Let me see here. That's kind of the meat of the matter.
Well, I see. So you sent us some notes on this, and I'm just looking at it now. It says one more thing: the small intestines were adherent to each other, and the tissue of their coats softened so that they tore in several places when handled. So that's not healthy bowel. So, and again, I'm not a trauma surgeon, but going through residency and such, I mean, I've been in these cases, and so I'm not an expert here, but speaking generally, they will run the bowel, and live bowel is pretty pliable. It's kind of soft, and it's got a healthy coating and such. Yeah. And this is probably dead bowel. So the adherence only happens normally inside. Everything just kind of slides around each other. The adherence means there's been a lot of inflammation or peritonitis there, or infection. And then if they tear, I don't know, it's autopsy, maybe that happened, but all that bowel is probably dead. That also could have contributed to the bleeding. So bleeding will also come from just dead gut. This poor guy, sometimes the movies get it right. Every time someone's gut shot, I remember in Young Guns, there was at the end, one of them gets gut shot, and they just watch him for like 2-3 days, stumbling around worse and worse, holding his belly, and then he like dies in the alley. Be like, yep, that's about what happens. It's terrible.
The most interesting thing to me about this is that, the fact that he got shot is ultimately what gets him in the end, but it's the literal bullet, like the literal damage the bullet did, is not necessarily what happened. It's just the path that it traveled and kind of what it bumped into. Even if it didn't rip or tear anything on the initial journey through, it sets off this sort of chain reaction in the body that
well, and
sort of combusts.
We didn't even talk about, when he started getting the chills and the intense febrile reaction, that's sepsis. So today we talk about sepsis as a bloodstream infection, and it old words might have been blood poisoning, but you're dealing with some systemic infection, and regardless, you got to control the source. And in this case, the source was inside the belly. So, that whole sepsis management thing, this would be a person in the ICU getting broad spectrum antibiotics, and the surgical team would be trying to figure out what was the source of the infection and controlling that. And then the medical team would be monitoring blood pressure and giving him antibiotics and controlling all those other things. So this guy would have needed, an extensive stay in the intensive care unit in the modern system. So
in the modern age, I think I'd say pretty confidently this gentleman would have survived. This would have been there could be complicated, but the likelihood
we'd have a good
survived.
Shot.
Heck of a good shot.
Wow. Well, thank you so much for going through not just this case study with us today. I think that was fascinating for me, as I'm sure it was for the folks watching. But thanks for just taking us through, all of this, offering a modern perspective on how, some things broadly speaking, and then getting specific here. So thanks so much for joining us, Max and Aaron. I really appreciate it.
Absolutely.
And I would urge all of our viewers to make sure you go check out the Poor Historians podcast. That's POOR Historians podcast. They cover all kinds of things in medical history. So if you're watching these videos, you'll probably enjoy that. And likewise, if you enjoyed this video, be sure to hit the like button, make sure to share it and send it to your friends. It's a great, easy, free way to support the museum. Follow us across all our social medias to stay up to date with what we got going on. And if you want to take your support to the next level, consider becoming a member. There's a link for membership in the comments. And with that, I think that's all we have today. This is John, Max, and Aaron signing off. Thanks so much for tuning in, everybody.
Thanks, everybody. It was a good time.
Thanks a lot. That was fun.